I'd like to welcome everyone to today's webinar, Caring with Compassion for Children and Families. I'm Stephanie Adler-Yuan, Director of Education and Training at the Schwartz Center for Compassionate Healthcare, and your moderator for today's session. The Schwartz Center for Compassionate Healthcare is a national leader in the movement to make compassion a vital element in every patient-caregiver interaction. Before we begin the formal presentation, let's go over a few details about today's webinar. The Schwartz Center's Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. Today's program will be 60 minutes long. The first 45 minutes will be a presentation, followed by a 10-minute question and answer session. We hope you'll share your questions with us. Today's program is being recorded and will be available on the Schwartz Center's website 2 weeks after the session. Please note that all attendees are participating in listen-only mode, but can interact with the speakers by using the questions pane, which should be appearing on your screen. If you have any questions, please just type them into the questions pane and send them to us, and we will address as many of them as we can at the end of the presentation. We'll be launching some audience polls during today's presentation as well, and we hope you'll participate in this interactive measurement tool. Finally, as you exit the webinar, you'll receive an electronic survey that we ask you to take a minute to complete so that we may capture your assessment of today's program. Your feedback is important to us. Thank you for sharing it. And now, it is my pleasure to introduce my colleague and our host for today's session. Dr. Beth Lown is an Associate Professor of Medicine at Harvard Medical School, and she's the Chief Medical Officer here at the Schwartz Center for Compassionate Healthcare. Welcome, Beth.
Thank you, Stephanie. Good afternoon, everyone, and thank you for joining us for our 2018 Compassion in Action webinar series. The National Compassionate Caregiver of the Year Award is one of the leading national recognition programs that elevates excellence in compassionate healthcare. Since 1999, we've honored outstanding healthcare professionals who display extraordinary devotion and compassion to caring for patients and families. The award is designed to be much more than a recognition for the individual honorees. The goal is to showcase best practices in compassionate care and to elevate compassion to a core value in our healthcare system. This year marks the 20th anniversary of this inspiring award, and as part of our celebration, we're featuring past finalists and recipients in our webinar series. Today's presentation by our 2015 National Compassionate Caregiver of the Year Award recipient, Dr. Rick Boyd, will be sharing stories from his 20-plus years of experience providing care to patients and families. I'm very, very pleased to introduce him to you now. Dr. Rick Boyd is a palliative care physician at Forest General Hospital in Hattiesburg, Mississippi. Dr. Boyd received his MD from the University of Mississippi School of Medicine in 1987 before completing a pediatric residency at the University of Mississippi Medical Center. A fellowship in pediatric critical care followed at Le Bonheur Children's Medical Center from 1991 to 1994. The medical management of critically ill children proved both challenging and rewarding for 21 years. Rick developed an avid interest in palliative medicine and end-of-life care. He attended the Harvard Medical School program in palliative care education and practice in 2005 and achieved certification through the American Board of Hospice and Palliative Medicine in 2006. In 2008, he became one of the first physicians to receive certification by the American Board of Medical Specialties in Hospice and Palliative Medicine. He holds certification in pediatrics until 2015 and maintains certification in pediatric critical care from the American Board of Pediatrics. In 2009, he established the Palliative Medicine Clinical Service at the Batson Children's Hospital in Jackson, Mississippi. After 22 years with the University of Mississippi, he joined the Palliative and Supportive Care Team at Forest General Hospital in 2016. Rick also enjoys teaching medical ethics, and in 2008 earned a Master's of Arts in Bioethics from the Medical College of Wisconsin. Quite a accomplished and interesting and wonderful resume. So welcome, Rick. We're delighted to have you.
Thank you, Beth. It's a pleasure to be here today. To begin with, I'd like to say that my best teachers have been my patients. With my introductory slides, I hope to identify the main objective of this presentation. That is, we can learn to express compassion through absorbing and reflecting the narratives of patients, families, and colleagues. Rita Sharon has pioneered the concept of medicine practice with narrative competence. This narrative medicine is proposed as a model for humane and effective medical practice. Though I don't claim to be an expert in narrative medicine, I have realized over the course of 35 years that the narratives or stories of my patients and of their families have molded how I practice. Not just how I practice competently, but how I practice compassionately. First, I had to learn to listen, because listening led to understanding. Dr. Dasgupta has proposed the idea that we should not so much strive for competence as much as we do humility towards the narratives we hear every day. I like this idea because it takes into account the possibility that we are prone to making assumptions based on our own experience that may not apply perfectly or even at all to the experience of the storyteller. We have to be open to new understanding and open to our own development, our own evolution. Dr. Dasgupta says in part, narrative humility acknowledges that our patients' stories are not objects that we can comprehend or master, but rather dynamic entities that we can approach and engage with. I have also enjoyed the writings of Rachel Naomi Remen and have had the great honor of hearing her speak in person on several occasions, including literally at her feet at workshops and seminars. She deeply honors the stories of her patients and reflects the ideas of Sharon and Dasgupta. I've learned that from her that everyone has a story to tell and that every story is important on its own. In the Deep South where I live, where I was mostly raised and where I certainly practice medicine, there's a deep tradition of storytelling. We tell stories every day. Storytelling in many ways comes naturally to me. I'm afraid sometimes listening intently to stories is something that I've had to work with through mindful practice. In part to this quote, I love the last part of this, where Dr. Remen says, "I think I have served people perfectly with parts of myself I used to be ashamed of." Over the next series of slides, I will tell you some of my own experiences during the first years of my career that helped me get in touch with the emotions that arise in the care of children. The first involves what I would call quite literally an emotional breakdown. While I was watching a TV news story, the story described a toddler who had died from a self-inflicted gunshot wound. As I recall, he discovered the gun while playing in his neighbor's home. This experience occurred at the end of my first year of fellowship in pediatric critical care. I didn't know the child. The incident had happened somewhere far from where I was learning how to be a critical care physician for children in Memphis. But I felt like I was welling up, and I just decided I would go ahead and let myself cry. I was by myself. But when 45 minutes passed and I was still weeping, I started to realize that maybe something more than just being affected by this single story was happening to me. I actually became terrified that I didn't have the right stuff for the career path I had chosen. I was worried that possibly I was just too emotional or maybe too emotionally attached to my patients. I felt enough distress that I approached our program director, Dr. Greg Stidham, just a fabulous person that I cherish as a friend. Instead of telling me to pack my bags as I anticipated, he actually told me that I had simply taken a different path. He encouraged me to stay in touch with my emotions instead of pushing them down. In my NCCY acceptance speech, I described an experience as a young critical care doctor when I was moved to tears when a baby died who had meningitis. I was so hopeful that we could make a difference and contribute to his recovery, and instead he passed away after a few days. I remember going in and talking to the family, his parents, and really trying to give them my condolences, but feeling like I was about to cry. I almost ran outside of the door and literally almost ran directly into the baby's grandmother. And I remember she thanked me. I was embarrassed and feeling undeserving of gratitude. I told her that I wish I could have done more. And then she corrected me by saying, "No, I'm thanking you for your tears." She taught me that patients and family members can welcome and appreciate your emotional response to their loss. I used a hospital curtain in an essay I wrote. The essay is called The Curtain, to illustrate how we close ourselves off from emotional responses. I observed years ago how hospital staff place these flimsy barriers to assure privacy, knowing all too well that they don't. Staff act one way on our side of the curtain and a very different way on the patient's side. In The Curtain, I describe a young girl, and in the essay I call her Sherry, who had sickle cell disease. When I first met her, she was admitted to the ICU with acute chest syndrome. This is a horrible disease for a person with sickle cell disease. Their lungs become incredibly stiff, and it becomes very difficult to keep them alive. At one point, I remember telling her mother and her grandparents that she would not likely survive. I remember how the mother sat at the bedside, really basically all night, waiting for that to possibly happen. But miraculously, Sherry survived. Her lungs were badly damaged, and she ended up staying in the hospital for a very long time. First, she was ventilator dependent, and then finally she could come off the ventilator, but she couldn't be managed outside the hospital, and she couldn't be kept alive outside the hospital, so she just stayed with us for quite a while. After she was discharged, I made a point to see her whenever I could at her follow-up visits. If I didn't go to the clinic, her grandparents would bring her to my office. I had these knickknacks on my desk or shelves, and she would always leave with one somehow. But later, she returned to our PICU critically ill again. Once again, she had acute chest syndrome. I had to tell her parents that I was putting her back on the ventilator and that I would sedate her first. So I went to go talk to her, and I was actually kind of surprised that she actually did wake up. And I could see that she was a little afraid, so I told her that I would give her some sedation, and she told me that was fine, but then she asked me, but when will I wake up? Unfortunately, she never did. She died without ever being conscious again. Hers was the first funeral for a patient that I ever attended. Before that, I was always very concerned over the reaction of the family, mostly that I would increase their grief. So I really honestly avoided funerals. So I went to this one with a lot of worry about that, but instead of compounding the grief, they were actually very grateful. And this allowed myself to grieve too. Sherry's grandmother gave me a stuffed animal that if I recall correctly, was attached to one of the funeral arrangements. This is a picture of that here. I still have it, and I really cherish it. At this point, I'd like to turn the program over to Stephanie for our first polling question.
Thanks so much, Rick, and thanks for sharing that story. So our first poll should be appearing on everyone's screen right now, and we'd like to know if you agree or disagree with the following statement. Allowing ourselves to be emotionally impacted by our patients' stories enhances our abilities as healthcare providers. So please select one of the following. Your choices are strongly agree, mildly agree, mildly disagree, or disagree. So please select the response that best reflects your opinion. Okay, wow, you all are very quick. So we've had a great response to this poll. So let's go on and share the responses. It looks like there is a strong majority here saying that we strongly agree that allowing ourselves to be emotionally affected by our patient stories enhances our abilities as healthcare providers, with 74% of respondents strongly agreeing with that statement, 14% mildly agreeing, and 12% agreeing. We have no dissent in this group. So Rick, do you want to share any thoughts on those results before we jump back in?
I'm very pleased with those results. I thought we would at least have some people that would disagree, at least mildly. I'm very pleased with that. I'm kind of stunned that so many say strongly agree, but I certainly would be one who marked that also.
Absolutely. So we'll move back to the presentation.
Thank you. Before I tell Batley's story, I just want to mention that the stories I tell from here on in the presentation are about children that I have known in my career and of their parents, and each of the mothers of the children that I will describe gave consent for the stories to be told. They also submitted pictures, which you'll see as part of the presentation. They're absolutely beautiful, and I had the great pleasure of talking with each one of them in the past few weeks, and so to catch up with them and also to make sure that I was as accurate as possible. And I hope to do that today, and because their stories are so important. So the first is about Batley. Catherine is her mother, and she was told during her pregnancy that the baby that she was carrying had a chromosomal anomaly called T18. She was told by physicians at the time that there was probably literally no way the baby would survive to delivery, and if born alive, Batley would only live for a few minutes or days. The baby was seen to have a huge hole between the main chambers of her heart, and it's called a VSD. So when Batley was born, they really didn't know if they had more than just a few minutes of life with her, and so they really wanted to share as much time with the baby as possible. And the hospital where they delivered was incredibly gracious and allowed them to room in for 6 days. This is Batley meeting her big brother, Hayden. During that entire period, they waited for Batley to pass away, never knowing quite when that would be. And she was having periods of apnea. Batley here is, I think they're placing an NG tube, and that would really become a big part of Batley's life for a large part of it to help her eat. So this is her at the end of that period. Eventually, after about a week, they were able to go home. For the next couple of weeks or so, this was a really trying time for the whole family. Batley was being managed under hospice, but Catherine told me that literally 100 times, hundreds of times, she said, Batley would have apnea. They placed Batley on an apnea monitor at night so that they could get some sleep. But her and Adam, Batley's father, would periodically just kind of lay Batley on their chest. Catherine said literally Batley kind of lived on one or the other parent so that they could monitor her closely. And every time she had apnea, they wondered if it was the last time that she would breathe and be with them. But they tried to manage to have a normal life as much as possible. But as you can probably think, that this would be a really difficult thing to do with such a situation at home. They did want to celebrate as much as possible Batley's life, so they started having birthdays every Thursday because Batley was born on a Thursday. And Catherine told me recently that Batley's grandmother still wears pink each Thursday in honor of Batley. By the time Batley was about a month of age, she was being followed by a cardiologist and a pediatrician, and eventually she was referred to the palliative care clinic at Batson. I don't think this was the first time I ever met Batley, but this was one of the clinic visits, and I really just kind of fell for her pretty quickly. Catherine says to me that she wasn't certain why she was being referred to the palliative care team, but I was glad to hear her tell me that she did feel better after she left. She felt like there was now at least a group of people that could understand her. She felt that the team understood what life was like for her family, and she remembers one of the team members telling her how difficult they understood it must be for her and Adam. As Catherine told me, it wasn't like I could call a friend whose baby had T18. At around 8 months of age, Batley had a cardiology appointment, and I went with her parents, literally just to kind of be support. And they were going to cardiology appointments on a regular basis, waiting for enough weight gain, enough stability to have a PA band placed, a pulmonary artery band. The large hole between the chambers creates a lot of flow into the lungs, and this creates congestive heart failure. So one of the ways that at least temporarily can be done is really a palliative procedure to help with the blood flow, is that a band is put on the artery to make it smaller, and they were waiting to see if that was possible. They had basically ruled out a total repair, and Catherine was pretty terrified of the idea of putting her baby through surgery anyway. She had actually been told in the past that prior to this that there was a chance that her baby wouldn't do well with anesthesia, and that Batley would not even wake up if it went under anesthesia. So on this appointment, though, I remember it so clearly. Her cardiologist told her the echo results showed that the high flow of blood into the lungs had actually created higher blood pressures in the lungs, and so sort of like a miraculous event, it created a natural barrier of blood flow into the lungs. So basically, the blood flow was balanced. Catherine was told that Batley could live even 10 to 20 years because that, prior to VSD repairs being available widely for children, was about how long children live with a VSD. Catherine told me that she could breathe for the first time since Batley was born. She had been told so many times to expect death, quote, any minute, end quote. And she told me that emphasizing the worst case scenario tended for her to basically squish hope. She told me that she would rather enjoy what time she has than worry about time she didn't have. So this began a period of time for them where Catherine just described it as wonderful. This is towards the next birthday in the second year of their life. Of course, Batley was still getting NG feedings through an actual nasogastric tube. So Catherine and Adam eventually consented to the placement of a PEG, a more permanent gastrostomy tube, to continue feedings. So during that second year of Batley's life, a little brother was added to the family. And Catherine says at that point they began to incorporate Batley into life instead of stopping life. She said it was just life. This is Batley during a visit to the clinic, and it just happened to be Halloween, so she was wearing a little costume. It was really cute. And this could be one of my favorite pictures of all time for me. Part of the great joy of being a pediatrician is that you get to be a big kid sometimes. So since the kids were dressed up on Halloween, I was too. And the team can remember that I didn't do this very often. And this is a sweet picture. This was during all that time. Here's Batley as a big sister. So Catherine told me the other day that she wouldn't have wanted to know the day her child died, or that she wouldn't have wanted to know the day her child would die. Unfortunately, she remembers it very well now. She said that Batley was 2 years, 3 months, and 6 days old. A treatment for constipation had most likely created an electrolyte imbalance, and Batley began to have seizures at home. She was taken to the emergency room at the Children's Hospital, and Catherine literally, in the beginning, felt like this was probably something temporary and that she could bring her child back home later that day. In fact, Adam had not initially gone, but he joined them later because it became pretty clear early on that things were very serious. Batley had developed a lot of respiratory distress, most likely had an aspiration event. And there was one point that Catherine says that Batley just wasn't there to her anymore. She really did not want Batley to die in the hospital. She knew she would remember the setting so well and wanted it to be a more familiar place. She literally said she did not want to remember the sights and the sounds of that hospital as Batley's last days. So she began to request that they went home. Batley was in so much distress, this really made the hospital staff uncomfortable, especially the ER staff, and to be honest, even me. I really felt like we could bring her into the hospital and have more control of the situation and be more supportive. But it became obvious to me after a while that this really should not be my choice or anybody else's choice other than Batley's parents. And Catherine looked at me and said, "Please let me go home and let me take Batley home." And I just couldn't say no. So we helped them get back into their Suburban and to go home. And I was hoping to make people more comfortable with this idea, and by letting everyone know that I would go with them. So I climbed into the front seat with Adam, and Catherine and Batley were in the back seat. We probably made it about halfway home when Catherine told us that Batley had quit breathing in the back seat. I'll never forget that moment. It's just I can still think about it every time I pass that certain location on my way home. It's just a very profound moment for me that will stay with me. I went on home to their home with them and spent a few minutes there until they came and got Batley's remains. But I will never regret having honored that wish. Next, I'd like to tell Ryan's story. Ryan was born on a March day, but would not come home for 3 months. He was found to have a neuromuscular disorder, a rare inherited disorder called X-linked myotubular myopathy. It left him weak, with difficulty breathing and eating. He was able to go home at 3 months, but he returned to Batson's Hospital at 2 weeks. 2 weeks later, so he was only home about 2 weeks. He was found to be dependent on mechanical ventilation, and Raven, his mother, told me how difficult it was to adjust because the diagnosis was so unexpected. She remembers seeing her friends and others have babies, and they were always bringing their babies home, and she says it was so hard on her because she had to go to the hospital to see her child. She would have to do this for 4 years. The first 2 years or so in the hospital were in hospital's ICUs. She remembers hearing little positive news, she told me, and I'm not pointing fingers because I'm sure I was part of this. She said that there was little encouragement because she was being approached on a relatively frequent basis about whether or not withdrawal of life support would actually be in Ryan's best interest. She was always scared that each acute illness might be his last and that he wouldn't survive. So in the meantime, however, Ryan grew and he developed as much as he could. He was eventually moved to the second floor for long-term care, where he became managed by the palliative care team. Raven was 23 at the time of Ryan's birth, and during the first months of his life, she tells me she was angry very often, but anger eventually turned into depression. She began to have panic attacks, and after 3 in 1 week that took her to the local emergency room, she was told by an emergency medicine nurse that she should be evaluated for depression. She really remembers that as a very life-changing event. She was able to be treated at the VA hospital, and it really made a huge difference for her. Raven is amazingly courageous to me, and she talked about this aspect, and she said that she wanted me to talk about this aspect because she's now an advocate for people to seek help for depression. She states that in her community and her family even, she was warned that people shouldn't know because they might think she was quote unquote crazy, but I think that she is very grateful for the help she got, and she's certainly benefited from it, and she's certainly doing much better now. But Raven had a lot of reasons to be upset and sad and depressed during that period of time besides Ryan. Her sister died during that time that Ryan was in the hospital. But despite all of the hurdles that life was placing in her way, she was able to finish cosmetology school, and she began to organize a home with the hope of bringing Ryan home. To bring a child home on a ventilator takes an incredible amount of effort on a parent's part. If you can imagine how hard it is to bring up a child anyway, to bring up one that's dependent on a machine to live, just doubles the effort that you have to make in the home. Basically, you have to create a small hospital in your home. So to get Ryan home, Raven had to undergo 3 months of training. Part of that training was done by this individual here. Her name is Alyssa, a friend of mine, and part of the palliative care team at Batson. This picture was submitted by Raven. But you may notice that picture was not taken at the hospital. Raven was able to get Ryan home and was able to take care of him at home. And this picture, I believe, was taken on their Make-A-Wish trip. So the Make-A-Wish organization helps fund wishes for people to do, and they often involve taking trips to places like Disney World. But for Raven and Ryan, they decided that they wanted to go to a Justin Bieber concert, which happened to be in Memphis. And there you go, two stars meeting each other. Alyssa actually voluntarily went to help make sure that Ryan was safe during that trip. There they are having a good time on the streets of Memphis. I remember those very well. They had approximately 1 year together at home. Raven told me about this, and I think it was really the first time I heard the whole story. After seeing the Christmas lights in their hometown square, their hometown is actually well known for their Christmas lights. They had just had a very good time there, and they decided to go on home. They had just arrived home, and Raven noticed that Ryan's color had changed. He was still in his car seat in the back seat, and they immediately took him inside the home to start CPR. Ryan had a nurse, and so she was able to deliver CPR until the paramedics got there, the EMTs got there. Raven tells me that the explanation that she was given was that he must have developed a plug within his trach, but she's not certain of that at all. She had been trained and knew how to remove trachs and change them out, and also to try to deal with plugs. So she's not certain that was what caused the change, but she told me that she may never understand, but I think she's learning to live with it. 2 days after Ryan arrived back to the hospital, after his arrest, it was clear that he was not going to respond neurologically like we had hoped. And so he was withdrawn from life support. We actually had him taken back upstairs to where he had lived for 4 years, or at least part of that 4 years, so that he could be with his hospital family. So in the end, Ryan was with both his hospital family and his actual family when he died. Raven's story and Ryan's story, in a way, doesn't end there, though. Raven now has a second son who also has the inherited myopathy. His name is Raylan. It's not as serious for him. It's not as severe for him. He requires a ventilator, but at night only. And instead of 3 months of training to take Ryan home, Raylan home, Raven only had to go through training now for 3 weeks because she was so trained by Ryan. And Raylan has a baby sister too, named Reagan. It's a very cute picture. At this point, I'd like to turn the program over to Stephanie for our second polling question.
Thanks, Rick. I'll just take a moment to collect myself. Thank you for sharing another wonderful story. So everyone, our second poll should be appearing on your screen now, and it reads, which approach do you feel has the greater potential for damaging hope? So you can choose one of the following options: placing emphasis on predictability or prognosis, placing emphasis on unpredictability, so focusing on individuality, or it doesn't matter. Hope cannot truly be diminished. So we're just going to give everyone a minute to think about their answers and probably also to collect themselves. I don't remember a webinar that's been so emotionally stirring, so thank you for that, Rick. And what we're seeing now in the poll is that we do have some different ideas here. but 66% of our respondents have said that they believe that focusing on prognosis has the greatest potential to damage hope. 28% have said that hope cannot be diminished, and that 6% reported that they feel placing emphasis on the unpredictability of an illness has greater potential to damage hope. So Rick, do you have any thoughts on those responses before we move on?
I actually thought we might see more in the last category. Doesn't matter, hope cannot be truly diminished. I guess I've, over time, have started to feel that way myself. Obviously, it's a very individualized reaction or response, but I guess I've seen so many times that people maintain hope no matter what the circumstances are. I do think that sometimes that hope shifts, and so maybe the goals behind the hope or the what people are hoping for can shift. But it seems like it's just a very human thing to maintain hope.
Yeah, and I'm sure it is a very individual response based on everyone's personal experience. So with that, I will leave it to you to continue with your presentation. Thank you.
Well, thank you. Our last story is Grace's story. Grace's mother is named Karen, and she was actually, at the time I met her, she was a new nurse on the very floor where most of the patients for the palliative care service were admitted. And I spoke to her also just in the last few days and enjoyed talking with her again about her daughter, Grace. And I remember Karen told me things look different in retrospect, and that sort of stuck with me. When Karen was pregnant, she found out that Grace would have an encephalocele. This is a rare birth defect that creates a sac-like projection or protrusion of part of the brain and its covering membranes through an opening in the skull. This was discovered while she was still pregnant, as I said. And in other words, though, a part of Karen's baby's brain would be outside the skull at delivery. So Karen, too, was told that Grace would likely not live for long. They were also told that literally she may measure her life, Grace's life, in only minutes. And so because of that prediction, Karen and her husband, Chad, spent the pregnancy months as really looking at it as really the majority of Grace's life. So they did things that they thought Grace would enjoy. For instance, they took Grace to a Trans-Siberian concert at Christmas time, and she remembers that very fondly. The delivery room staff was also very flexible with Grace and her mother and father, so that they allowed a lot of visitation during the time right after delivery. In fact, Karen remembers that at one point they placed Grace on a pillow and kind of passed her around, she says, just like she was a queen. So in retrospect, Karen told me that she appreciates that people were honest with her, but she was also appreciative of the times when people left room for hope, such as when Grace had an MRI shortly after being delivered, and they found that not as much of the cerebellum was in the sac as first suspected. In fact, only about 10%. So that actually was a surprise, but it also presented a problem for Grace's parents. They had to decide, were they going to allow surgery to correct the defect? They did eventually agree to the surgery, and they prepared themselves to accept whatever came. So I remember Chad telling me that on one of the visits to the palliative care clinic, we were doing prenatal counseling to help them through what we thought might be a death in the future. That he told me that we had prepared him for his daughter's death, but not so much for her life. In other words, he was more prepared to be a bereaved father than a father. So I'm glad that we were doing a good job of that, but it made me realize that we have to keep open our thoughts to all possibilities. And Karen and Chad began to focus on quality of life, rather than length of life. And Karen tells me that she was intensely focused on therapies in the beginning, like PT and speech therapy, but she was eventually able to relax as Grace started to develop and bloom. And she really certainly has grown, and she certainly has developed. This is her graduation picture, it's so cute. Karen tells me that Grace really enjoys music, and she still gives credit to that Trans-Siberian concert. This picture reminds me to say that I have focused on the moms of these stories, but the fathers should not be neglected. All the parents that I've known over the years are truly my heroes. Grace is now 7 years old, and she is also a big sister now to little brother Micah. And I had to include this picture because it's just stinking cute, to be honest. So I will close with this quote and tie it into my presentation. I really feel like I've evolved over the years from a young physician with almost kind of delusions of influence over basically what's the uncontrollable, to hopefully a wiser, older physician who embraces what Dr. Remen refers to as mystery. She says that mystery seems to have the power to comfort, to offer hope, and to lend meaning in times of loss and pain. In surprising ways, it is the mysterious that strengthens us at such times. I used to try to offer people certainty in times that were not at all certain and cannot be made certain. I now just offer my companionship and share my sense of mystery, of the possible, of wonder.
Well, Rick, this is Beth, and I just want to thank you for that very, very powerful and poignant group of stories. It's hard to imagine holding those stories inside you, and your sense of being with those patients, those family members, and really accompanying them on their journey is such a wonderful lesson to us all. I wanted to ask you really how you really learned to do that, how you moved from being that distraught young trainee to someone who was able to walk alongside patients in the midst of such uncertainty. Really, I mean, so many of these families and their little ones faced dire prognoses, some surprises, ups and downs. How did you learn to just walk alongside and be present with them?
I think it had a lot to do with me being able to place myself in their shoes, at least partly. Several things happened in my own life at the time that helped me realize just how vulnerable anybody can be to hardship in life. So I think that's part of it. But I began to realize just how much I was really found meaningful the art that is part of medicine, the ability to be present for people. So I think it was just in really trying to examine closely what their experiences were and to really try to absorb them and to try to understand them. And sometimes that takes several visits and several conversations to really do.
That is for sure, trying to understand their lives. I want to remind the audience to please write in some questions into the chat pane. We have time to turn them over to Rick for his comments, so please do jump in there and send us your questions and comments if you have some. While we're thinking about this, Rick, I want to ask you too about the issue of prognosis and trying to help families understand that and cope with the uncertainty that's so often inherent in any attempt to share a prognosis. How do you think about that? You asked, that was one of your polling questions, so I'm curious to hear your thoughts about that and how you frame it with families.
With children, I used to as a critical care doc, I used to use the statistics and the data that was available to us to explain what average lifespans would be, how things should go according to the knowledge base that we had. But I started to realize that quite often I would just be wrong. So when I began my transition to palliative care, I actually would find that I was meeting families of children that had that I had treated in the ICU, and they would literally tell me, that they remembered me. Sometimes I wouldn't remember the incident, but they would remember that I had told them that their child probably wouldn't survive their first birthday or live longer than a couple of years or so, or just a few weeks, or whatever the prognosis was, and they would be so proud to show me that their child had far outdone that. So I began to realize that the thing I needed to say was that every person writes their own story, and that we will walk with them day to day. This is what the statistics show, but we certainly don't know how long their child will live, and that seemed to be better accepted. I can imagine that it was, but it also seemed that it also was the truth.
Yeah, so interesting. We have a bunch of questions coming in, Rick. I'm going to ask you some of these. One person asked whether you have a sense of spirituality that strengthens you to continue your work.
Yes. I've always felt grounded in a sense of spirituality. My upbringing was not in a particular faith tradition. My father was Southern Baptist, and my mother actually was raised as a Buddhist. She was Japanese, but spirituality was important to both of them, and I've explored that in many different ways. I've spent my teenage years and young adult life in church, but I don't claim right now a specific faith tradition, but I do feel very close to God and to the idea that there is something beyond us.
And I'm sure that keeps you afloat. We have a question here. In the face of a terminal diagnosis or an illness with no cure, how do you help patients and families maintain hope?
I think part of it is, we talk about reframing the hope. I guess my hope is that we can do that when we sit down and talk, but I really try to find what's important to them and try to support what we can support. When things aren't realistic, I guess in our eyes, it certainly seems still realistic to them. So I have to try to understand why. And when they're making requests that seem beyond what can be done, I try to find out also what they're emphasizing and what could be driving that to see what part of it we can maintain. It is a difficult thing. You have to be realistic, obviously, but you can't be. But you can't, like Karen was saying, it seems like it's best to just provide a little space for hope. Sometimes, once again, if we can reframe hope into hope for certain events or making to certain events, or hope for no pain or hope for a seizure-free day, things like that.
Yes, depending on their circumstances, and finding out what is it that matters most to them. Here's another question, Rick. As caregivers, we often struggle to be comfortable in those uncomfortable moments. How do you teach others to be present and to stay outside of judgment?
I think the best way I have found over the years is to try to model that. I certainly have not been the best role model at times. I'm not going to say that I am mindful all the time or that I'm present all the time, but especially young trainees, they're really watching, and so I try to be mindful of that. I try to present myself the way, once again, like the golden rule, like I would want, to be treated.
For sure. People really learn from what we do much more than what we say, and they learn from who we are. Another question came in about the composition of your palliative care team. What roles do chaplains play, for example?
We here at Forest General, there are 4 people on our palliative care team. 3 are providers. There's a nurse practitioner and 2 physicians. That is the actual team, but we are very, very partnered up with the chaplains. They're an incredible part of what we do, and they are consulted on every patient that we see, and we meet with them in IDT and discuss the patients. They're hugely important.
Do they support you as well, Rick? I mean, certainly you must have your down times, your times when you are feeling a sense of loss and want that kind of support?
Oh, no doubt that they do. Sometimes they have asked me at the most profound times if there's something wrong. It's amazing. I wonder just how much is actually visible on my face. But yeah, each and every one of the chaplains here have been incredibly supportive. I really have enjoyed getting to know them. And yes, they really have. They can do that formally, but I think I've enjoyed the times when they've just kind of taken me aside and asked me if everything was okay.
Yeah. So how do you sustain yourself in this work? The work itself can be sustaining, but what is your way of thinking about that? Because there is so much talk about compassion fatigue and so forth. So what do you do to keep yourself afloat?
I completely buy into the notion of compassion fatigue, and I have had many times during my career where I probably have been over that line. I've had feelings of being jaded. I can't. My wife Lisa can tell you how many times I've come home and talked about getting an alternate career. There was a whole period of time I was definitely going back to school and probably law school. It's but I have found the best thing I can do is find things that have absolutely nothing to do with health care, but further my own development or expand who I am. So I'm even in my mid to late 50s now, I'm starting to pick up new things. My most recent is I'm trying to become a cyclist. I say it that way because obviously almost anybody can ride a bike, but I'm a slow cyclist. But I mean, I've really enjoyed my time on the road now. Just sort of kind of have a time where I can be focused on nothing but me and the bike and the road, and that's a really good thing for me. Music is huge for me. I've found again my love for live music, so I'm going to concerts anytime I can, anytime that I can. There are so many artists that I didn't see when I was younger because I was too busy or didn't take the time. So I've kind of got a list of people, and every time I see that they're doing a tour, sometimes it's their out of retirement tour, but every time I see that there's a tour, I've actually I try to get tickets. So I've actually traveled a pretty good distance sometimes just to go to a concert.
Well, we do what we can to sustain ourselves. That's funny. There are a couple of more questions that have come in. One is, they're actually kind of related. One is do you think it's important to involve the patient's siblings in the care? And also, do you have child life specialists on your team, and what are their roles like?
We don't have child life specialists here at Forest General, but they are certainly a huge part of what happens every day at Batson Children's Hospital. They're terrific. I can't say enough for child life specialists. Yes, and I do think siblings should be involved. Obviously, some of that depends on how much the parents want them involved, but they're often can be neglected. When they're not the focus of the parents' attention, which is understandable given the circumstances, they can obviously be affected. So child life specialists are incredible in being able to point that out, helping parents cope, helping them to develop a strategy for keeping everybody involved.
Yeah, for sure. One more comment here about how you provide support, that at times families just can't be of that kind of support to each other because they're so much pain in what they're experiencing. I'm wondering about your thoughts about that. See a role for uniting a family that might sometimes either be turning away from each other or just turning inward so much that they can't even reach out to the ones they love because they're in pain. Well, how do you think about that, and how do you see your role in trying to mitigate?
We actually found that we did have a role in that. You know, when I became a palliative care physician in pediatrics, I didn't realize that I would be entering areas that I really may not have the best training background in, but sometimes I felt like a kind of a combination of social worker and psychologist and all the different disciplines. Not that I did any of those any as well as they do themselves, but I sometimes felt inadequate. But quite often people even told me that sometimes they felt like they had just been at a therapy session though when they came and they sat and talked with us. I found that being present and being a good listener and just really trying to help them hash things out was the best thing to do. But staying aware, I mean, obviously over time I've also developed kind of a bit much better ability at reading body language and understanding when things just aren't really as good as maybe they're portraying. It's not often that you can get, say, parents apart during a clinic visit, though, to kind of talk to one or the other. So, and it wasn't unusual, I guess, for one or the other to approach us about trouble they were having. So, yeah, raising a child with a complex condition can be incredibly difficult, not just on siblings, but on marriages, and many do unfortunately come to an end.
Yeah, so stressful. Well, I want to thank you again, Rick, for sharing your expertise and your wisdom and your long history and experience with all of us and to the people who are listening. I'm going to turn the program back over to Stephanie to wrap up the webinar, but please accept our thanks and please do thank the parents for sharing the beautiful photos and their children's and their own personal stories with us. It is only moving to know that we share a common humanity. So Stephanie, let me turn the program over to you now.
Thanks, Beth. And just to add to the gratitude, we've also in our questions pane been seeing countless thank yous from our participants. So thank you from them as well, Rick. That was a really wonderful webinar. And thank you, Beth, for such a beautiful job hosting it. So that really brings to a conclusion our webinar today on caring with compassion for children and families. We hope you enjoyed. This is the fourth in our series this year of Compassion in Action webinars, focusing on the exceptional individuals like Rick, with whom we've recognized with our National Compassionate Caregiver of the Year award over the last 20 years. And as for the rest of you, we know you're busy, but we would really appreciate if you could take a moment to complete the survey that you'll see when you exit today's program. If you'd like to share it with colleagues, again, it will be on our website within the next 2 weeks. And we thank you for joining us and hope you'll have a great day.